It is my pleasure to introduce this year's speaker for the Medical College of Wisconsin Stuart Wilson Historical Lecture. Presented since 2009, this lectureship is now named after a giant in our field we all know, a founding member and past president of our organization. His wisdom shared at the podium and at the microphone over the years is remembered by us all. Our speaker this year, Cliff Cove, needs no introduction. He is the face of surgical quality and patient safety in this country. His contributions birthing, sustaining, and growing the ACS NISQIP have saved innumerable lives. Under his watch, the cozy NISQIP meetings of a decade ago have evolved into the enormous surgical quality meetings. He has received millions in research funding, and printing out his CV would be a major contributor to deforestation. Despite his administrative duties at the ACS, he has an active colorectal surgical practice at UCLA. His mentoring has steered the lives of many trainees, in particular through the ACS Quality Fellowships. On a stretch, I reached out to Cliff, presuming he'd be too busy. He said yes, and even weathered the meeting being canceled last year. Although this is labeled a historical lecture, we will learn about the past, the present, and the future that is yet to be written. His talk is titled, "The History of Achieving Surgical Quality, Informing Our Current Efforts." And I'm going to put on my NISQIP cap to listen to the talk. It's all yours, Cliff.
Great. Thank you so much, Alan. And it's really a pleasure to be here and an honor to be here. And I really wish this was in person because I am terrible at giving these virtual talks, but we have to do what we have to do. I really look forward to coming to a meeting in person, hopefully in the next year or so. I'm sorry that I'm changing the title because I know that we had picked the title a couple of years ago and I actually didn't have it written down what it was, but I think this will fit the history of achieving surgical quality, informing our current efforts. And as I go through and learned about Dr. Wilson and what he has achieved, it's really apropos with this lecture in achieving quality. Being an investigator, a teacher, and a clinician, and being awarded an achievement award for that is in line with what we're all trying to achieve as we're trying to give great quality to our patients. And so this is really an honor to speak on behalf of Dr. Wilson and the lectureship. I also want to have just one more picture here before I start the talk, and that's about Alan. Alan is a really as we all know, he's a really tremendous clinician. He's inspiring. He's a great role model for many of us. He's a leader and has vision. And I am really just so happy that I can call him a great friend. And Alan is really a great person, human being above all that. So, Alan, thank you for inviting me, and I really appreciate it. So, I wrote here in the next 30 minutes, but I've actually haven't really practiced this talk. So it might actually take 15 minutes or 45 minutes. But what I'd like to do is what Alan said, is to remember some important historical people and ideas for surgery and our commitment to quality care, and then move to share where we are now and really understand where we are now and how much we've achieved. And then the third piece is about envisioning how we can further improve our surgical care or our surgical improvement. So first, remember, when anyone talks about quality and quality improvement and quality evaluation, two names come to mind, and it's not within surgery: Walter Schuhart and Edward Deming. Walter Schuhart was a physicist and a statistician and an engineer back in the 1920s. He worked at Western Electric, and he very quickly realized that there's a lot of variability in the data that we get. So he understood that things are not always kind of the same way every single time, but there's some variability. And he came up with this notion of assignable cause and chance cause for the variation, which later came to be known as specific cause of variation and common cause variation. And he was very famous for doing that and understanding what is here in this graph is what people call the Schuhart graph or the process control chart that we use even today to figure out if we're kind of looking at all the variation, is there a problem that we should be concerned with, or is that just variation that's commonly seen or by chance seen? Now, the second person on the map on the page is Edward Deming. Edward Deming was a disciple of Schuhart, and Edward Deming was also actually a physicist and an engineer. And he is famous for, among other things, what he called the Schuhart chart, but we later came to be known as the PDCA or the PDSA, Plan, Do, Check, Act, or Plan, Do, Study Act cycle. And he gave talks on this about controlling the process to get reliability and produce a better product. And he was actually in Japan at a conference talking about it. And these Japanese companies actually asked Dr. Deming to come in and help them with their productions. And he is the single most important person for what we now know as the Japanese post-war economic miracle. He helped a number of Japanese countries improve themselves to be leader in their industries to produce high quality, low cost, high value products. And Edward Deming was recognized and still is recognized in Japan. And when he came back to the States, was soon recognized from the National Academy of Sciences and others for lifetime achievement in manufacturing and the quality principles and quality assurance. Now, I start with these two people and give you the dates of the 1920s to the 1950s, only to show that in surgery in the 1910s, before Schuhart and before Deming, we were thinking as surgeons about how do we get better. So many people have heard this story about Ernest Codman and his end results idea. And this picture I'm sure you've seen before, that he was championing the idea that every one of us as surgeons should record on a card, an end results card, things about our patients. Why they had the operation, what operation they had, and the results. What happened? Did they have a complication? How long did they stay in the hospital? Did they get readmitted? And this is back in the 1910, 1920s. And the idea he had was that everyone should do this, his colleagues. He was at one of the Harvard hospitals. And then we should take all our data and we should compare and see what worked well and what didn't. And this comparing for improvement was one of the first forays into what, a professional should do in the scheme of professionalism, in this theme of professionalism. Well, unfortunately, Codman was met with a little bit of resistance in saying that, well, yeah, we don't need to do that. We think we're good. We don't need to record that data. Codman eventually left the hospital, opened up his own, and actually tried to do these things and used and operationalized his end results idea. Another person that you may have heard of, probably not as famous as Codman, is Dr. Franklin Martin. Franklin Martin is probably the individual most responsible for starting the American College of Surgeons. He was the executive director for the first 20 plus years. But probably more important than that is that he really got the college together to get the clinical congress developed, created, and off the ground. His real priority was to support surgical education. And he even started a postgraduate school. He opened up a hospital so surgeons could really understand how surgery should be performed and train further if they wanted to. His ideal for clinical congress was that each year surgeons would come together, buy tickets to observe how a local famous surgeon would see patients in the clinic in the morning, operate in the afternoon, and after dinner, listen to evening presentations of scientific studies. And this is what he wanted to do. And it started with him in Chicago with a bunch of people, and he built it from there. This is actually in the archives in the Chicago building of the American College of Surgeons. It's a letter dated October 23rd, 1914, and it is actually an invitation to the first annual meeting of the ACS, the first annual clinical congress. And you can see that the clinical congress was actually only 3 weeks later, but they didn't have to make any airplane reservations because that wasn't invented till 40 years later. In any case, this was the invitation to the American College of Surgeons Clinical Congress, first one. You can see that the Board of Regents, the Board of Directors of the college at that time are names you are familiar with: Kreil, Finney, the people who started famous clinics in Minnesota, Charles Mayo and Albert Ochsner. So Martin got together some giants to start this foray into surgical quality, surgical education, and figuring out how we do better. You can see in this letter that they expected 1,500 surgeons back in the 1914 clinical congress, this first clinical congress. And not unlike today, it says that no matter what you do, just reserve hotel accommodations. And this happened to be in DC. This was at the Willard Hotel and the Shoreham Hotel, which are still hotels that we can stay in today, and the Raleigh, which is not. A name that you probably are not familiar with, but you might, his work, is John Bowman. John Bowman was not an MD. He was a PhD. He was actually not a doctor of philosophy. He was a doctor of letters. He was a doctor in the humanities. And he was the first person, the first director that Dr. Martin hired to be at the college. And he was there at the college for 11 years. To let you know about his background, before he came to the college, he was the president of the University of Iowa. So he was not in healthcare at all. And so they hired him, and he came in, and what he saw was that there was extreme variability in when he looked at care being offered at hospitals. Clinical case records were variable, laboratories, they were done, staff organization, the personnel, all these things were extremely variable. So he became a leading proponent of hospital standardization. And he really did this. He worked at the college, and he really did this because he felt that he and a group felt that if a surgeon is going to operate in a hospital, the hospital must meet some level of standard. And so that really came up to the minimum standards for hospitals. And so he stayed and got this program off the ground, and I'll talk about it in a little bit. But as far as Bowman, what happened with him, he later became the 10th chancellor at the University of Pittsburgh. So he's a person that, although we might not be familiar with his name, we do recognize the work that he's done, because this hospital standardization program, you'll see, this actually became the Joint Commission several decades later. But this is the first minimum standard document for hospitals, and this was in, I think, 1924. And there are just 5 pieces to this minimum standard document. The first piece talks about a medical staff. If you're going to have a hospital, you have to have staff, physicians and surgeons privileged to work there, and not just anyone can come in, but you have to set a bar above which the medical staff would be at that hospital. The paragraph, the second part of it, was that what should the medical staff, what should the criteria be? And so they had to be graduates of certain medical schools. They had to be competent in their respective fields, and that was defined. But I thought was very interesting was that the medical staff had to be worthy in character in matters of professional ethics. So it was important to the college at that time that we're not even just getting great scientific minds who are intelligent and smart, but people who are worthy in character, which was I think still true today of the whole surgical physician groupings. The third piece, or the third section, is really in line with what quality and safety is, that the medical staff, the people who work there, would have to review and analyze their clinical records of their patients. So case review, M&M, things like that. And whether it's free patients or pay patients, it didn't matter, that we had to look at and review the care that we were given. Part of the standardization that he put into play was that the case records, or the medical record, had to be standardized. Often at the time, there were reports that people would be taken care of, have huge operations, and there was no records kept. Nobody knew what happened. And so he even spelled out what should be there. And it's largely the same things that we're working on and we're doing today. What's the chief complaint? The HPI, the past medical history, the labs, the x-rays, the working diagnosis, the final diagnosis, condition on discharge and follow-up. The things that we still do today were part of the standards of what should be in the medical record and what should be kept when we're taking care of patients in the 1920s. And finally, the committee at the time, led by Bowman, and actually Codman was also on this first committee, was to the two areas in the hospital that they thought were very important for surgery were, and they had standards for, were the laboratories and the X-ray department. The laboratories addressing the chemistries and bacteriology, serology, and pathology. And of course, X-ray at that time had radiography and fluoroscopy. So this was what was started by Bowman, and it goes on till today. In the 1950s is when the Joint Commission started, when the College of Surgeons said, this is kind of a little scope creep. We don't want to keep on looking at the hospitals for this. Somebody else should do it. We want to concentrate on surgery and surgical quality and not the whole hospital, because that expanded. And so in the 1950s, the Joint Commission was started and took over that. The final person I want to share with you in all these pictures and of historically famous surgeons is Alan Cannavale. And you might not have heard of him, but he is a regent. He was a regent at the college, and he was a president of the American College of Surgeons in the 1930s. He was a professor of surgery at Northwestern. And I add him for the AAES meeting is that he developed special techniques in thyroid surgery, and he advanced science. In doing that, he published his scientific research. So you can see that this is a paper in the control of hyperthyroidism by thyroidectomy, results in 100 cases. It was published actually in JAMA, the Journal of the AMA, in 1927. So I guess JAMA does take case studies. So in any case, this is important because it's not important just to deliver quality of care, but it is important to advance science. So our historical leaders were continually striving for quality of patient care, as well as improvements in these areas: data and professionalism, education and training, setting standards, and innovation and initiatives. And so this is really important for us to know. And so where do we go from there? So the next part of the talk is really sharing where we are now, some probably 100 years later. What have we done in the last 100 years to shore up and to improve quality and to measure our quality? So if we look at surgical quality manifesting in 2021, there are a lot of methodologic and scientific and programmatic advances. And I'd like to just kind of go through some of these because it's a really, I think, a robust and an impressive list of things. And so let me share some with you. So now in 2021, we have a number of data registries where Codman was trying to collect it one at a time with himself and his colleagues. We have a number of data registries. Alan said I work with NSQIP, and that's true, but there are many others. The STS, I don't know if this pointer works, but I'm going to use it in case it doesn't, or it does. The STS database is even older than NSQIP. The trauma TQIP database, other specialties of orthopedics, endocrine has SESQIP, and bariatric and vascular, and a whole host of other registries that we turn to figure out how we're doing. We can look at them, we can benchmark, we risk adjust. We use it obviously for research and publication, advancing science, but a lot of what we do with these registries is to figure out how we're doing and where we can get better. In addition to data registries, we have spent a lot of time and effort figuring out what exactly we want to measure and how. So many of you have heard of the National Quality Forum, or the NQF, which is the body that helps develop and endorse performance measures. And this is a copy from a couple years ago of how to develop measures and submit the measures to the National Quality Forum. As many of you know, the measures get submitted to the National Quality Forum, and once they're endorsed by them, they can be used in a payment program by CMS, or they can be used in kind of regulatory measurements, benchmarking, and so forth. And so it's important to know, and it's really interesting to look at as how we rate and what are the criteria that we develop measures on. And these are the 6 or so criteria. What's the evidence for a measure? Importantly, what's the opportunity for improvement, or what's the care gap between the opportunity to get better? The reliability and consistency, the validity, the feasibility and usability and use are all things that we look at, or all things that the National Quality Forum looks at to develop a measure. If we look at the measures that have been developed in surgery over the past several years, this is a report from a couple years ago, that there are probably about 60 or 70 endorsed measures by the National Quality Forum in surgery. One thing that you can see is that it's across many different types of surgeries, many different specialties. Most of them happen to be outcome metrics, but there are some process and lesser structure. And I think composites are starting to get increasingly used. Each of these have pros and cons about this. I won't go into that, but this is just to get an idea of how we're taking the data and how we're defining the metrics so we can have apples to apples comparisons and benchmarking across one registry, across multiple registries, across multiple specialties. And this is a really important piece of standardization of how we use the data to measure. Analytics is very important, and each of the registries and each, of the analyses are make advances. I'll just share a few things from within NSQIP. And if you look at the authors here, it's almost a who's list of people who have really made big contributions in analytics and data. But if you look at what was happening and what work was done, we had a lot of data. We looked at outcomes, but we figured out, we need to risk adjust, and we need to risk adjust better. And how do we do it better than before? So coming up with a new way to do it. Once we can do that and risk adjust, how can we do it in a better way to take into account that we have different levels of groups that we want to model for? So hierarchical modeling or clustering better than non-clustered data. How do we do that if we have a registry and we have to pay people to collect it? Should we collect 1,000 variables, or can we do it with just 100, or can we do it with just 7? So the idea of parsimony into the statistical parts of risk adjustment became very important. And then also how we take the data and kind of turn it on its head and make predictions of how patients to do it. And that's how we came up with the ACS NSQIP risk calculator. So a lot of analytics really, and computing power and programs and statistical software have really helped advance since the days of Codman. And I didn't show you his spreadsheets. It's kind of like a handwritten Excel spreadsheet, but certainly the analytics that we're doing now and how we're evaluating the data has advanced since the time of Codman and Martin. I should say before, let me get into the quality programs. If you think about finding problems and finding the issues for quality, the registries, the performance measures, and the analytics are really important. But if you also think about the work that Bowman did and how we analyze and review the data and analyze and review what we do in the hospital, that we have a lot of things kind of baked into the fabric of what we do to identify problems, to address the quality issues. And so if you think about M&M or case review or sentinel event reporting and root cause analyses, if you think about peer review and event reporting, if you think about finding problems based on the information we get from the CAPS survey of patient experience or the safety attitudes questionnaire, the things that we have in 2021 have really helped us to identify our gaps, our huge gaps, whether they're in our registries, whether they're in day-to-day work that we're doing, we can find the gaps. So if we think about finding the gaps, how do we do the quality improvement? So the next thing that I want to share with you are some of the quality programs that we at the college or other organizations have done. And this is a picture. I made this slide and it's not very good. The background is supposed to be at least the United States, and every dot is where there is a program of the American College of Surgeons. It doesn't work out very well. I apologize. But you can see in the fonts that there are a lot of different types of programs that the American College of Surgeons has. And so there are verification accreditation programs like the Commission on Cancer or the trauma verification, the level 1, 2, 3 trauma systems. You can see on the left, there's all the data registries that we house, and then some of the support programs like Strong for Surgery, an enhanced recovery program, and this new program that we're developing now called Thrive, which is to look at value-based care. But you can see that there's a number of ways that we are trying to develop programs to help improve the care that we're giving. And if we focus just on the left side, all of these programs follow this this same paradigm of these four components: setting standards, building infrastructure, collecting data, and verifying through a third party, which is the college. We verify for external peer review because you know, if a hospital says, oh yeah, we're great, well, let us tell you if you're meeting the standards, and let us, you know, establish some level of public assurance. And so if you think about that, that really follows what Bowman wanted to do, or what Bowman actually did do in the 19s, 20s, 30s, 40s, up to the 50s, is setting standards so that they do that. But instead of the infrastructure for a hospital to run as a hospital, these programs really target specific clinical areas where surgery is apropos and related. So whether it's cancer or trauma or bariatrics or geriatrics or emergency surgery or vascular, thoracic, GI, all of these are honing in on specific areas and setting standards that hospitals should meet, and what infrastructure and resources are needed, and what data are needed to address and improve the quality issues. Along the lines of quality issues are quality improvement strategies and organization. So when you think about if you know, we get reports that say, you know, your SSI is too high, your readmissions are too high, you're too expensive and whatnot. We have a lot of strategies that we put into play, and there's a lot of organizations that help us. So if you think about, I don't know, in the last, well, before the pandemic, in the last year, what kind of strategies have we used to improve our care? And I'm sure you could think of a number of projects that you've been associated with, or that you've led, or that you've been part of. And if you think about all the strategies that you use, there's a lot. When we have a high SSI rate or a problem with the, you know, something or other, there's audit and feedback, there's putting in a clinical pathway, there's education and training, simulation, guidelines, standardized care, improvement cycles, and go on and on. We have a lot of these, and we use a lot of these, and these are a lot of times routine, but this is not what they had necessarily in 1910 when Codman was putting his data together. But we have these things now, and we have a number of teams that can work on these. If you think about the support that we can gain and from organizations that are just about quality evaluation, quality improvement, it's huge. The Agency for Healthcare Research and Quality, the NCQA, the National Committee for Quality Assurance, Joint Commission, things in Canada, the Canadian agencies, Anesthesia has a Patient Safety Foundation, the National Academy of Sciences, on and on and on and on. So we have a lot of things that are in 2021 that Codman didn't have, but in the last 100 years have been really developed and really become very robust. In terms of the professionalism and the quality improvement, I do want to add this, that this is a statement that I don't know that many people know about this. I actually asked Dr. Hoyt, who probably knows the history of what the college does, or not in the history, what goes on in the college. And he mentioned, like, have you ever read our statement on professionalism? And it's on our website, but there's a statement of professionalism as it relates to quality improvement. And I want to read it because it's inspiring. Our profession is accountable to our communities and to society. We accept the following responsibilities. And there's a whole list of bullets, and I just chose 5. Provide the highest quality surgical care, abide by values of honesty and altruism, participate in lifelong learning, participate in self-regulation, and improve care by evaluating. So these are some of the things that are in this statement. It's a very long statement, but if you want to be proud of your profession and what you do, read the statement. It's really terrific. Now, in 2021, how would we sum up what we do to achieve high quality surgical care? Well, we want to provide high level care. So surgery quality of care is provided. We then evaluate our quality, whether it's through registries or performance measures or M&M or Sentinel event reporting or the surveys or anything like that. And when we find gaps, we do quality improvement. We perform quality improvement. We have many, many strategies for doing. There's lots of organizations for doing it. We have quality programs for doing it. And that was just in the College of Surgeons. Every society has quality initiatives that they perform. So we do quality improvement, and to get back to surgical quality of care and providing that. So this is really now 100 years later. These three components, again, are very robust, each of them on itself. And to think about, the end results idea, which nobody wanted to do back 100 years ago, to now all the things that we have in these three boxes, in these three buckets, is really quite remarkable. And when you kind of see it on paper or see it on slide, it's really something that we can be proud of in surgery. And it's not to say that all the specialties have what surgery has, because I think that there's certain things. Surgery is episodic. Surgery is very outcomes. We have outcomes based. We have a lot of metrics that we can measure. That clearly there are certain things we want to measure more long term, but we can see a lot of what we can do within a measurable period. We are very good at and applicable for measuring quality, and we do it very well, and we do a lot of quality improvement. So this is what we've done up to now in 2021. So I'd like to talk about, just for the next 5 or 10 minutes, about what we might envision going forward, not for 100 years, but maybe for the next 5 or 10, to what might we put into play in improving even further what we can do. And so a question that I know that a lot of people have, and I'm constantly thinking about this, and we think about this in the division at the college all the time, is this question. Are the quality improvement efforts, are the QI efforts optimally improving surgical quality? Are we doing a good job of what we're doing? And so really, it's really not focusing on the quality of care that we're doing. It's not focusing on our measurement or the evaluation of quality, but it's really focusing on what we're doing when we perform quality improvements. So if I take it further, we can ask these questions. What should each of our quality improvement efforts deliver? I mean, if we do a project to address the SSI rate, or, the fact that what we're working at one of our hospitals is on-time starts, or anything like that, what should each of our quality improvement efforts deliver? And I've distilled it down to 3 things, at least, that make sense to me. So first, we should know if the initiative that we performed was successful. And what this means is that we first have to define what is success. And in defining what is success, it's really defining what is the goal of the project. So when I was reviewing projects a little bit ago, somebody was putting into a service line a protocol. And so how are you going to improve it? We're going to put in a protocol. Well, what's your initiative? Well, we have to develop the protocol. We have to then we have to put it into play, and then we have to make sure that people do it, and then we have to, take it from there. And so what would make this successful? I don't know, just making the protocol. Well, there's a lot of steps in terms of that project, and it's very hard to tell if the project is successful unless we really define what we're trying to do with the project. What it came to be was that they had to develop the protocol. They had to get the protocol accepted by all the different stakeholders. And when I say stakeholders, all the different surgeons, the nurses, the pharmacists, because they were part of it, anesthesia, the head of the hospital or the leadership of the hospital doing this. And so a lot of different stakeholders had to accept the protocol. Then they had to implement the protocol. So how are they going to do that? And that was like, they wanted to initially put it into the order sets and IT, put it into electronic health record, but that took way too long. So then, there were other strategies that they had to do. Then after they did that, they didn't know if anyone was using it. So then it was measuring compliance of the protocol, which was another huge step of the data piece. And then, did this protocol affect the change? Did it decrease the length of stay, decrease readmissions, and decrease their complication rate, which is a whole other piece of idea that they needed to address. And so knowing if the initiative was successful sounds like a simple thing, but it really is a lot of pre-planning and understanding what you're trying to do. Another piece of whether it's successful or not is the piece of whether this initiative is successful more so than doing nothing. So if we put a quality improvement program into place, is it better than a quote unquote control group? And so we know that for a lot of the effectiveness studies, when we want to have RCTs and level 1 evidence over and over and over again, how important it is to have a control group, because we need to know that this is better than the counterfactual, than the status quo. And a lot of times when we don't have that, we don't know the answer to that. And sometimes when we measure the control group and we say that there's no difference, that is, or they both get better at the same time, that is surprising. That is sometimes disheartening, that the initiative kind of figured out and resulted that way. The final thing about success is how and why. And so everyone knows that if you put an initiative, or everyone thinks if you put an initiative in place, that is why we get a better outcome. Well, the infamous Hawthorne effect is that, you had a bunch of workers and they suddenly, I don't know, I can't remember what they were doing. They were making buttons, and the leadership of the company said, oh, it's because of our good culture, our good organizational culture. Of course, that's why they make more buttons. And the managers of the place like, oh, no, we changed the lights, and that's why they could see better. And that's why they made more buttons. But in reality, some people think that, well, the staff knew that they were getting measured and they made more buttons, regardless of what the reason was. And it's probably not even accurate what I just said. But the point is that knowing why the initiative worked is really important if we want to continue the initiative, if we want to revise the initiative or expand it or replicate it in some other setting. If we think it's the one reason and it's actually not, that's an important piece of information to know. The second piece of information that we should get delivered from a quality improvement project is have adequate information to know what to do next. So if we have a quality improvement program and we kind of put it into play and it's working, working not great, not terrible, but it's working. What do we do next? Do we keep going? Do we expand it? Do we revise it? Do we sunset it and stop it and de-implement it? And a lot of times we probably don't have enough information to know what to do next. And a lot of times these quality improvement programs just languish. And some people are like, well, that's what happens. That's the natural history of a quality improvement program. But if you think about quality improvement programs are what we kind of put into it. It takes up time, it takes up energy, it takes up people's efforts, FTE potentially, it takes funding, and there's opportunity costs. And so being very responsible to what we do in terms of quality improvement is important for just that piece as well. Finally, we're scientists, we're researchers, we're investigators. We are trying to advance what we do, and learning from the effort is clearly very important. Not just, learning from the effort for the effort itself. So if we can learn from it and improve our particular improvement that we're trying to do, but also learn for the greater good. If we learn that this thing works because of this reason and this is applicable to this type of project, a audit and feedback project, or implementation of a guideline project, but in other specialties and other parts of the hospital, in other settings, that's really worthy. And learning from the effort is extremely important. So it was interesting because after we kind of got through all this, we decided, all right, well, let's put pen to paper and see how well quality improvement is being performed. So at the ACS, we looked at some local kind of quality improvement projects. And so again, for the background, the College of Surgeons has several different quality programs, and each quality program requires annual performance of a specific local quality improvement project. So the trauma program and the bariatric program and CO's Cancer Commission on Cancer, they have a standard that says everyone here has to perform a quality improvement project. Pick whatever you want. It could be from the registry. It could be something you find at some conference, but pick a quality improvement project. So we just randomly picked 30 projects across a bunch of hospitals, and we studied them. And so here are the results. So, well, first of all, the top quality improvement projects that were performed in this random assortment were clinical pathway implementation, number one, audit feedback, number two, and education. This was not That's not statistical, but just kind of just for interest. But here are the real findings. First, the project needs tended to be identified and very clear. So remember I said, we should all figure out what the aims and the goals of our projects are. They did this very well. And these are, again, just randomly assorted of the 2,500 hospitals that participate in at least one college program. These are from them. Project needs identified and clear. However, the project goals were imprecisely defined. So we knew what we needed, but we didn't precisely define what we were going to do. And it was often unclear if the project was successful or not because the goals of the project were not precisely defined. The interventions of what the plans was, what the strategies were not well planned. The protocol was often underspecified. We were just going to do this, and they didn't really think about it in deeper levels. Deficits in the resources, preventable implementation problems were kind of noted. What's also very important is that contextual or local factors were not collected in the vast majority of the efforts, and explicit positive and negative learnings. The third aspect of what we should do is learn from it was only collected in less than 1 in 5 of these quality improvement efforts. If you think about that, there's probably 2,500 hospitals performing a quality improvement project each. And some of them have more than one program in it. So that's probably more than 2,500, let's say 3,000 projects. The amount of learning that we could do from 3,000 projects a year collected in a better way would be amazing for surgical quality improvement. And I think that this is one of the reasons we talk about what can we do better in terms of quality improvement. The conclusion of this, just very short, probably not, well, I don't know if we're ever going to kind of share this beyond the talk here for the AAS, is that there may be opportunities to improve the performance of local quality improvement. We can improve how we do quality improvement. So you might ask how. So if we take a quality initiative, how would we figure out if we're doing quality improvement better? Same way we figure out if we're doing quality good. Quality well, as we would evaluate. So if you talk to card-carrying people who evaluate, they said, there's a lot of different ways to evaluate, and they go off and talk about all these types of things. And this is going to make your eyes glaze over right here, but have no fear because tried to simplify it. So if you think about the spectrum of a quality improvement initiative that goes from having the intervention or the strategy or our technique of quality improvement, and then we implement it, we put it into play, and we put it into our service line or into the operating rooms or into post-op care or post-discharge, whatever. And then when it's all done, we have the third step, which is the analytic part of did it all work out? There are 3 principal things to evaluate, and I'll give you their names, but the names aren't very important, but what happens in these evaluations is important. So formative evaluation really looks at the strategy of the intervention. What is our strategy? How are we doing it? Are we doing it with audit and feedback? Are we putting in a guideline? Are we putting in a pathway and using the EHR to do it, order sets? What is our intervention and what is our strategy? If you think about what we do as surgeons and what we do as groups of surgeons, we strategize all the time. We strategize how we're going to take care of a patient. We're going to strategize what we do in the operating room. We strategize how we're going to get our groups together, how we're going to be more efficient, how we're going to be more valuable, how we're going to, do this or that. We strategize. We have strategy retreats, and we strategize a lot. It would make sense that we would want to strategize our quality improvement project. And from the 30 that we saw just off the cuff, or the ones that we've heard over the years at the Quality Safety Conference, the strategies could get better. Not only strategizing the intervention, but strategizing how we implement, how we plan to take this pathway and put it in so that the surgeons follow it, and the anesthesiologists follow it, and the nurses follow it, and everyone follows it. And we know that they're doing that. How we implement it, it has to be strategized as well. So when we get to this implementation piece, there's something called process evaluation. And the key piece to think about in terms of the process evaluation is this. When we plan in our heads an implementation, and we can see, we close our eyes and we can say, this is how it's going to work. When we actually put it into play and when we actually implement it, very rarely, almost never, does it happen exactly the way we planned. And so this is the adaptability of implementation. Something gets changed, something gets tweaked, something gets majorly tweaked, something has to be redesigned in terms of doing that. That's the flexibility of what we do in implementation. However, actually process evaluation kind of looks at the delta between what was planned and what was done. And this is very important for a number of reasons, because it helps us see how we might sustain the project, important pieces of how we replicate the project, how we put it into other places in our hospital, into other specialties. So the process evaluation lets us know how we do in terms of the implementation. The third type of evaluation is impact or outcome evaluation. And I think this makes the most sense to surgeons, in that we do something like, did it work or not? Did the readmission get lower? Did the SSI get lower? Did our cost curve get better? Whatever it is, once we have that, once it's done and we have this data, we think a lot in terms of an outcome evaluation. What all of these things do, the formative, the process, and the outcome evaluations, is lets us know what are the next step decisions. Again, should we keep it going? Should we expand it everywhere? Should we revise it minimally or maximally? What resources is that going to take? Or should we sunset it? So these are certain things that will be really important and helpful as we do that. And the key part is that evaluating what we're doing before, during, and after is going to be something that is probably a good thing for all of us to do. My last example, and I have maybe 10 minutes left, and I keep on saying we have 10 minutes left, but this is a cool example. This is a program that occurred in England. So Matching Michigan is what it's referring to is that many of you have probably heard of the work that was done in the state of Michigan by a group from Hopkins that went there to work in the ICUs to decrease their CLABSI rates, the central line bloodstream infection rates. And what they did was they worked with 100 or so ICUs there, and they got the rate of CLABSIs in this quality improvement program to become a median of 0 for the length of the study. It was amazing. It was a New England Journal paper. Peter Pronovost was the PI of the work. It was heralded as, it's even better than sliced bread. So after that, a group in England said, we have a problem with bloodstream infections. Let's match Michigan. Let's do what they did, and let's do it here. However, we're going to, the work in Michigan was not funded enough to do a large enough evaluation. We're going to put this into play, and we're going to do an evaluation. We're going to have goals. We're going to have data. We're going to have a control counterfactual group. We're going to, have all our questions laid out. We're going to, do all the things of having an evaluation before, during, and after. And so they did this in 200 plus adult ICUs, and this is what they found. So the intervention demonstrated a 60% reduction in reported central venous catheter bloodstream infections in adult ICUs in England. Great. Amazing. People were like, wow, that's amazing. However, that amazingness is nuanced by this. Improvements were also seen in hospitals who didn't participate in the intervention. So they had hospitals that did this bundle and did this other behavioral intervention. They got better. And hospitals that didn't, they also got better. And when they joined, they eventually joined it because it was a stepped wedge, or a type of stepped wedge. When they joined the initiative, they all got better kind of at the same rate. The nuance goes further by this. Improvements were seen in the study hospitals, so the hospitals that participated in it, but in ICUs who didn't perform the intervention. So in a hospital, 3 ICUs were in it and they got better, but 7 ICUs were not doing the intervention and they got better. So they wouldn't have known all this information if they hadn't done a control group and this type of study design in this. They wouldn't have known this if they didn't do an evaluation before, during, and after. But if you think about, was it successful? The 3 questions. Did it achieve success? Do they know what to do next? And what did they learn? Having an evaluation of this was important, because if you only had that first line, if there was a reduction in 60%, I suspect the different things they would do after it would be not the same as if knowing the other two results as well. So when you think about these tripartite way of achieving quality of care, the thing that really we can envision to do is evaluate our quality improvement. And evaluating our quality improvement means hopefully that we will perform quality improvement better, and then that leads up to improving our quality of care. And from the website of the AAES, it's promoting the best treatments for endocrine disease through discovery and application of this. So I don't want to leave you just with this high level thing, just evaluate. But there are 4 things that we could do when performing our next local quality improvement initiative. So first, explicitly define the goals and the key questions to answer. This is in deference to the quote unquote fly by the seat of your pants strategy of doing quality improvement, but it's really explicitly defining what exactly we're doing and what we're trying to answer. Second, identify the components and carefully think about what are the inputs and resources, what are the activities that we're supposed to do, what are the outcomes of interest, the contextual or local factors and assumptions. I can tell you the biggest assumption that I keep on hearing that is not an assumption that turns out to be in our favor is that we assume that people are engaged and will do what we think they will do. In point of fact, when we do these studies, people are engaged. People tend to think that, yes, of course we would do quality improvement. And of course, yes, this is really important. However, I don't have time. I can't do it on nights and weekends because I'm already working on 3 things in the nights and weekends. I have already, 17 different quality improvement projects that I'm doing during the day. And plus I have my day job. The assumptions that we make of whatever the project is to work, we need to write them down and then figure out along the way, was this a good assumption or was this not? Number 3, ensure data issues are addressed. That's very important because we want to measure whether with qualitative data or quantitative data or both in a mixed methods way, how we're doing, and we want to make it very data driven. Finally, evaluate. We should evaluate our strategies before of the intervention. We should evaluate the implementation itself, and we should evaluate the initiative afterwards. If we do all this, I think that there's a good chance we will do better, and then we will also learn more. I want to end with this, and this is part more of the professionalism statement, and this is about, and this was, I think, written in deference to Dr. Codman. As a profession dedicated to quality care and committed to scientific knowledge and research, and now this is kind of advancing our knowledge, we should base care and improvement on the best available scientific evidence. We should uphold scientific standards, promote research, and create new knowledge and strive for the appropriate use of this knowledge and these findings. So I want to thank Alan and everyone else at the AES for this very kind invitation to participate in your conference. I was really taken by what our history is when I kind of put it all into slides and how it started with these notions of trying to do the right thing, and then in the last 100 years of how we've tried to operationalize what we would do to improve our quality. And hopefully this vision will resonate with people and we can start working on our next projects together. So Alan, thanks so much. And it's all to you.
Thanks so much, Cliff. Most informative presentation. Thank you so much on behalf of the AES. I think you've given some good direction in terms of where we need to go in the future. We'll begin our next session shortly. So hop back to the meeting room. We're a couple minutes behind, but we can handle that. For the next session, will be our last scientific session of the day, and then immediately after this, we'll start the presidential happy hour. And at that time, we'll be announcing the 2021 Research Award recipients, along with some other recognitions. And then we'll have a fun, novel breakout session for the happy hour session. So go ahead and log off this session, jump into our next scientific session. Thank you so much, Cliff.
Sorry, I thought I had an hour.
You're good. Thank you.
I should read the directions better.
Great. Thanks.